Okay.
Like I said, for want of time, we will just go straight and we'll ask Dr. Caleb to take us through the presentation. And then once he finished, we can then ask questions and coordinate and all that. So at this point, with all due respect to all of our folks who just joined and those who were there earlier on, once again, I apologize for the technical problem that we had from the beginning. And so, Dr. Caleb, I hand it over and want me to change the slide, just prompt me and I'll change it for you.
Okay, thank you. Thank you very much. I know it's good morning here, and I would like to say thank you for the privilege inviting me to be part of this program. It's a privilege for me to be here to share ideas with you. Once again, sorry for the hitches. So we'll just quickly set the ball rolling. Next. So this is the outline we'll be following. It's a very important topic we have, and I would like to commend the organizers for such a topic as a very timely one. We'll look through the introduction, definition of metabolic syndrome, what it's all about. We'll look at a few epidemiology, the risk factors, clinical evaluations, implication, management, summary, and a take-home message. And I have something special for you this weekend. Yeah. So metabolic syndrome, other literature refers to it as insulin resistance or syndrome X. I remember when in medical school, one of my colleagues went for interview, oral exams, what we call vivas. So he was asked, he came to tell us, he was asked about metabolic syndrome. So he told them that he knows what is metabolic and he knows what is a syndrome. But when you put the two together, he doesn't know. So we'll try to understand what metabolism is. We'll also try to understand what syndrome is. And then this time, I'm sure we know when we put the two together. So simply put, in simple terms, metabolism has to do with all the chemical changes that take place in the body. So a lot of things that happen in the body at the biochemical level is a whole lot of chemical changes that go on in the body to produce energy. And a syndrome is simply a group of signs and symptoms that correlate with each other and often associated with a particular disease or disorder. So putting the two together, in simple terms, is just the chemical changes that occurs in the body that produce a peculiar kind of symptoms and signs, so that when we see those peculiar symptoms and signs, we can easily point that this is pointing into the direction of a metabolic syndrome. And it's a global pandemic involving millions of people in different regions of the world at this particular time. So this is a very important topic before us, and I hope that we'll have a fruitful discussion. There's an argument out there whether the metabolic syndrome is a unique entity or not. But that one, we'll leave it for the jury out there to settle that one. But the most important thing is that the individual components of this metabolic syndrome must be taken seriously because it has great connection to morbidity and mortality. So I'm sure that as we go on, we'll get to understand the individual components. Now, so what is metabolic syndrome in clinical terms? So there are various definitions of metabolic syndrome. Different bodies have their different definitions. But what I want to present now, I think cuts across and is generally accepted. So there are 5 criteria. And to qualify for metabolic syndrome, you must have 3 out of these 5. So we'll quickly go through the 5. So the first one is that there should be an increased waist circumference. And the waist circumference has a lot to do with ethnicity. But generally, if you are a man, your waist circumference shouldn't be more than 40 inches. And if a woman, so that goes to about 102 centimeters. And if you're a woman, your waist circumference shouldn't be more than 35 inches. That also counts to about 88 centimeters. Then we have what we call the triglycerides. So if you do a lipid panel, you go to the lab and you ask them to check your lipid profile. This is one of the indices that you'll be given. Triglycerides shouldn't be more than 1.7 millimole per liter. I know you guys are used to milligram per deciliter. Then another component of the lipid test is what we call the HDL cholesterol. That's a good cholesterol. And if your good cholesterol is less than 40 milligram per deciliter in men and 50 milligram per deciliter in females, then that is also a problem. Or you are being treated for a cholesterol problem. Then the 4th criteria has to do with the blood pressure. So if your blood pressure happens to be more than 130 and 85, it's also problematic. Or you are on blood pressure medications. The 5th one has to do with the fasting plasma glucose or your blood sugar. If your blood sugar is more than 100 milligram per deciliters, or you have been diagnosed with type 2 diabetes, this also qualifies for metabolic syndrome. So these 5 criteria, you need to have 3 out of these 5 for us to say that you have what we call metabolic syndrome. Next. So like I mentioned, that there are various definitions and there are various classifications and criteria. The issue is that it's not really about the various definitions of criteria, but generally all the various terms agree to the prognosis and management of metabolic syndrome. So the commonality is that in terms of prognosis and how to manage it, they are all speaking the same language. And at the biochemical level, there are a lot of biochemical processes that go on. And these biochemical processes involves markers like C-reactive protein, interleukins, plasminogen activator, inhibitor. And just to say that these inflammatory reactants predispose the individual to subsequent risk of cardiovascular disease and type 2 diabetes. So if you have, and this is one of the points we'll be laying emphasis on, that if you have metabolic syndrome, because of the biochemical processes that go on, it is pro-inflammatory, it is pro-thrombotic. In simple terms, if you have metabolic syndrome, you are at increased risk of developing cardiovascular disease and type 2 diabetes. And it's also important to know that each of the 5 points that we have, criteria that we mentioned, each of them is individually is a risk factor for cardiovascular disease. Now, the etiology next. The etiology, in fact, research is still going on to be able to glean out the etiology. But for now, what we know is that it's a complex interplay of genetic components, environmental or lifestyle factors, including obesity, lack of physical activity, and unhealthy dietary habits. There is an element of insulin resistance, adipose tissue dysfunction, and chronic inflammation. So all these factors contribute to the cause of metabolic syndrome. And it's a complex interplay between all these factors. Now, we'll move on to a few numbers. In the US, the National Health and Nutrition Examination Survey looked at a huge data set between 1988 to 1994. And these data pointed to the fact that the overall prevalence was 22%, with an age-dependent increase. So as the age increases, the prevalence also increases. So between 1998 to 1994, metabolic syndrome was 22%. Now, when this same data was analyzed again between 2011 to 2016, it shot up to 34.7%. So you can see a significant increase from 22% to 34.7%. It is a US data. Metabolic syndrome is increasing globally. In fact, the global prevalence puts it between 20 to 25% of adult population. In Europe and Latin America too, is increasing. And over there, 1/4 of the general population is reported to have metabolic syndrome. China has been increasing in terms of metabolic syndrome. And like I mentioned, it increases in age. And 40% of people have metabolic syndrome in their 6th decade. So you realize that this is a pandemic now, this is a public health problem. In fact, those days, the major issue had to do with acute infections and tuberculosis, infections, killing people. But now medicine is advanced, public health has advanced, and with the advent of antibiotics and all that, those acute infections are really not of a problem now, even though we are mindful of antibiotic resistance. But now the main issue had to do with non-communicable diseases, and we all have to be watchful. Next. So this is just a picture just to show us of the same data set I mentioned. If you look at it, generally increasing with age. Next. So the risk factors of metabolic syndrome. Body weight. Increased body weight is a major criteria. But it's important to note that there's a small group of people with normal weight, but also have metabolic syndrome. Remember, there are 5 factors. And if you have 3 out of the 5, you qualify or you can be diagnosed as having metabolic syndrome, even though the body weight is a major factor. So there's people we call Appoh body. So there's central obesity at the abdominal region, fat around the abdomen. It's a risk factor. Age is also a major factor. Remember when we looked at the data set, we said it was increasing with age. Race is also a factor. Smoking is another major risk factor, and physical inactivity, another major risk factor to developing metabolic syndrome. And then having a genetic history of metabolic syndrome. Remember, when we look at the etiology, we said the genetics also play a very important role. Next, please. Now, clinical evaluation. Because this is a very more important public health problem and health challenge, I wrote here that we have to work closely with your primary physician. Very, very important. There's no hard and fast rule. Once you are diagnosed with a metabolic syndrome, your continual follow-up is key. And in that case, you need to work with your primary physician to know your follow-up routine, depending on how well you are doing. You need to know the numbers. And I've highlighted the blood pressure. It's something we can all do. Measure your waist circumference. Your primary care physician will help you with the other labs, the lipid panel, and the fasting glucose concentration. The reason why we're saying that you need to work closely with your primary physician is that you need to be evaluated regularly. For example, if you are not at risk, we can say every 3 years you should see your primary physician. If you have obesity, if you're obese with no comorbidity at all, your primary physician can say, okay, you let me be seeing you every year for a follow-up. But if you're obese with a comorbidity, we would like to see you after 6 months. And when we see you after 6 months, the question will be, have you lost weight? If you've lost weight more than 5%, then we are good to go. We'll continue the management. But if you've not lost weight less than 5%, then your primary care physician will employ other ways of helping you. And once you meet your clinical person, you'll be screened and treated for other comorbidities that comes with it. Because once you have metabolic syndrome, it predisposes you to other conditions that will be looking out. So it's very important that you work closely with your primary care physician. And if you're a health worker and a doctor, you also need a doctor to be able to manage you and to make sure that you are accountable. Now, next. So we'll now move to a very important area. What are the implications of diagnosis? So if you go to hospital and your prescriber says or health worker says you have metabolic syndrome, what does it mean? What are the implications? Number one, once you are tagged with a metabolic syndrome, it means that you have a high risk of developing cardiovascular disease and other obesity-related disorders. It also means that you have a high risk of developing type 2 diabetes. In fact, if you are diagnosed with metabolic syndrome, you have a twofold increase of developing atherosclerotic cardiovascular diseases, and you have a 5-fold increase risk of developing a full-blown diabetes mellitus compared to those in the general population. What are the implications of metabolic syndrome? It also means, very importantly, that the good news is that at the point of being diagnosed of having metabolic syndrome, it means that you will also benefit from an aggressive, and the word is aggressive, aggressive lifestyle modification. So hope is not lost. With an aggressive lifestyle modification, focused on weight reduction and increased physical activity,
Back, I'm in
you
my
can be
class.
helped. Now, next place. So to give us a broad spectrum of the various predisposition, we are saying that you are at risk of cardiovascular diseases and developing type 2 diabetes. And this is just to give us a range of the cardiovascular diseases we're talking about to bring it home. So it includes hypertension. So if you are tagged with metabolic syndrome and nothing is done about it, you can even develop a stroke, heart failure, myocardial infarction, what we call heart attack, cardiac arrhythmias, cardiac arrest, a whole range of cardiovascular diseases. So metabolic syndrome is not a child's play. Like we said, the good news is that with an aggressive lifestyle modification, you can be helped. It doesn't end there. The next place, there are a whole lot of other implications of metabolic syndrome. It is associated with liver diseases, liver fibrosis, liver cirrhosis. It is even associated with liver cancer, kidney diseases, sleep problems. And one more thing we tend to overlook, it's associated with cognitive decline and dementia. Very important. So that one with metabolic syndrome compared with the general population, the one with the metabolic syndrome has a higher chance of developing a cognitive decline and dementia, which is very important. And a lot of times we tend to overlook this. Now manage the next slide, please. How do we help with metabolic syndrome? Like we said, hope is not lost. First of all, you need to be counseled to really understand the implications we spoke about previous slides. You need to understand what the metabolic syndrome is about. You need to understand what contributes to your metabolic syndrome. Remember, we stated 5 criteria, and you need to score 3 out of those 5 to be tagged as having metabolic syndrome. The counseling is important because you need to own and take responsibility for your own health. Remember, we said you need to work closely with your healthcare professional. So the counseling is supposed to help all these areas. Another reason for the counseling has to do with the fact that a lot of these people also have an underlying depression. So with the counseling, the psychosocial aspect will also be taken care of. And the next principle of management had to do with treating the underlying cause by reducing weight and increasing physical activity. We also need to treat the cardiovascular risk factors so that if your blood pressure is high, would you be treated with the blood pressure? If there are problems with your cholesterol, that will be treated and all that. So working closely with your healthcare professional is very important so that all this will be taken care of. Another important principle is that in terms of management, it's interdisciplinary. So you need cardiologists who have to come in if need be. The internists will have to come in. Dietitians will have to come in, very importantly, pharmacists, exercise specialists, and a host of other healthcare professionals. So once you work with your primary care physician, when it's time to coordinate with other specialists, the primary healthcare professional is better placed to guide you into that. Now, the last aspect of our presentation had to do with the lifestyle modifications next. A major component of management, like you mentioned, has to do with the lifestyle modification and weight management. And still, this is where the multidisciplinary approach we mentioned comes in. We need a long-term, sustainable way of lifestyle modification, of weight management. And that includes diet, exercise, and for selected patients, pharmacotherapy will need medications. And for another group of people, they'll need surgery. So just a few points on each of these modalities. There are different kinds of diet. We have the DASH diet, which is for basically towards hypertension, all kinds of diets. But the Mediterranean diet has proven to be of help when it comes to metabolic syndrome and when it comes to weight management. So it involves a lot of high fruits, vegetables, nuts, grains, and the rest. And over here, when you meet the dietitian, they're able to give you the specifics. They are able to help you to calculate based on your activity level, your age, your sex. They're able to calculate the amount of calories you need in a day, and they're able to help you to plan your meals so that there'll be some form of deficit to help in weight reduction. So a diet is very important. The next, please. Yeah, exercise. Exercise. The standard is that you need a recommended daily minimum of 30 minutes of moderate intensity, such as brisk walking, and it should be regular. And it's best to combine aerobic and resistance training. Like I mentioned, those who are not able to sustain their weight through diet and regular exercise, with working with your healthcare professional, at some point we may have to throw in some medications to help. And at some point, we will also have to recommend a bariatric surgery to help you to reduce weight. Next. Good sleep hygiene. Decreased alcohol consumption. It's difficult to estimate the units of alcohol one needs to take. There's no completely safe level of drinking, but generally it's advised that you don't go beyond 12 units of alcohol per week, and this should be spaced across 3 days or more. Stress management is also very important in dealing with metabolic syndrome. Like we mentioned early on, the various risk factors would also have to be treated. Hypertension will have to be treated. We also, the cholesterol issues, if they are there, they will have to be treated. Diabetes will also have to be treated. So this is a combination of a whole lot of medication, of problems. That is why we are calling it a metabolic syndrome. Yes. The next slide, please. Yeah. So in summary, we are saying that metabolic syndrome is serious. There's a twofold higher increase of developing cardiovascular diseases. The good news is that with lifestyle modifications, you are able to help. And next slide. So the next few take-home messages for us is that we need to practice a healthy lifestyle and target a BMI of less than 25. Increase our physical activity, very important. Engage in at least 150 minutes of moderate intensity physical activity in a week, and daily at least 30 minutes. We need to look at our diet again. That comes with planning, combining good diets with our everyday up and go work and all that. Sometimes it's not easy, but we need to discipline ourselves to get more vegetables, more fruits, to make sure that our diet is okay. We need to reduce the carbohydrates, reduce our salt and saturated fats, and quit smoking and avoid excessive alcohol intake. Having a good sleep is also really helpful. Next slide. So this weekend, this is what I have for you this weekend for all of us. Check your blood pressure this weekend. Know your numbers. So the challenge for us all to check our blood pressure this weekend. Check your blood sugar this weekend. Measure your waist circumference. For the men, yeah, the target is 40. Calculate your BMI this weekend. And after doing all these four, take action. We now know the criteria. If you happen to cross any of them, take action by seeing your primary care physician and start working with your primary care physician. Remember, it has implications of developing cardiovascular diseases. And we've given an example of a tall list of the various cardiovascular diseases you are prone to. Remember, it also implicates you in developing type 2 diabetes. But the good news is that with an aggressive lifestyle modification, you can be helped. Thank you very much. And we are open, next slide. We are open to questions, discussions. Thank you.
Thank you so much. Thank you so much, Doc, for this wonderful presentation. I personally want to thank you for sharing this with us. And then what we're going to do now, and again, thank you for all of you who have joined us this evening for this powerful presentation from Dr. Caleb. I would now invite Reverend Dr. Kendrick Kpodo and Senior Frank to moderate the question and answer time. But before I hand over to them, I have my first question, then they can take over from me. So Doc, I heard you clearly. Now, my waist circumference is 36, and when I scan on a scale, I am maybe 1 point shy from being 200, about 199. They're approximately 200. But every time I go for my annual checkup, my primary physician jokingly tells me I'm still obese. Is it just having fun with me, or there's something that I need to pay attention to? Thank you so much.
Yeah, thank you. Yeah, so there's something called BMI. So your weight over your height in meters squared. It's not a perfect guide, but it's one of the indices we have, and it's very useful for us. So that gives us an idea whether you are obese or not. So usually it should fall between 18 and 24.9. So once you cross 25, then you are overweight. And you cross 30, it's getting worse. So we have obesity, we have class 1, class 2, class 3, but whatever it is, as much as possible, when we measure your weight over your height in meters square, you shouldn't cross 25. But remember, also in the presentation, we said that there's a small group of people who are slim, but still have metabolic syndrome. So the weight is one of the indices, and the other indices, as we mentioned. So they all go together to detect whether you have the metabolic syndrome or not. But the good thing is that I heard you mention annual checkup, which is very good. So, and it means that you are working with your primary care physician. So that is very good, and keep it up. Once at a point there's a red flag, they'll quickly pick it up early enough and deal with it. Thank you.
All right. Thank you so much, Dr. Dzunu. This is an incredible, presentation. I've learned so much. Sometimes you think you know everything, or you've read, widely, and you know a lot, but you hear one of these and realize that, oh man, I never knew about this. So thank you so much. This is absolutely timely. So we are now in the Q&A section. It's going to be about 20 minutes. And already have my first person that want to ask docs. There are going to be a lot of questions coming your way. So if we can try as much as possible to, make it straight to the point, so at least we save some time. Hopefully there won't be too many questions that we'll all in. But Mr. Benga, Santa Benga, you have a question for Doctor?
Thank you, Doctor. Please, I just want to ask, during your presentation for Syndrome X, epidemiology, I could see that the data for Africa was not presented. I don't know if it's an issue in Africa. And also, can we say now that it's also a public health issue yet, or due to the prevalence and everything? So these are my questions.
Okay, thank you. Yeah, so we have data challenges in Africa. For the individual components of it, we have some data, but it's still inadequate. It is true, it is a public health problem, as I mentioned. Now, this is the era of non-communicable diseases. Like I mentioned, the acute problems, a lot has been dealt with, but now non-communicable diseases have become a public health issue. Thank you.
Yes, sir. Thank you, sir.
Thank you, Mr. Benga. Okay, guys, so now the floor is open. If you want to ask the question, you can just raise your hand, or you can, type your question in the chat, and then I can read out to Doctor. But yeah, the floor is open now. And if you have any question, if you want Doctor to maybe reiterate something that he said, or there's something that wasn't clear during the presentation, please feel free. And let's ask Doctor the questions. And Doc, I have one for you myself.
Yes, please.
And that is, excuse me, I saw it in the presentation, but I just want to ask again. Given our cultural tendencies towards salty and oily foods, right? What is considered good oils? And what's considered good salt versus bad oil, bad salt? I know in Ghana we cook with anything, especially so because I want to be able to, communicate with my mom and my sisters for them to know that this is a health issue. So at least they will start making some changes. So what's considered good oil and good salt? And what would be the daily limits that you would recommend or advise to address, the strong link between high oil salt intake and hypertension? Thank you.
Yeah. Thank you very much. So for a start, if you're able to avoid both, you are good to go. Remember, I mentioned that it's multidisciplinary. So the various specifics, the dietitian will be the best place to help you with the specifics. But as much as possible, be able to avoid the oil and salt, fine. You can progress gradually. Once the food is cooked, no added salt. Traditionally, the cooking style is also a problem. You have to see the oil on the surface of the food to know that, yes, you're giving good chop money. So all these things, but as it is now, it's difficult for me to say this oil is good, this oil is bad.
Okay. So there's no specific oils that are good, because I know I'm not a doctor or anything, but I hear oils that are rich, like saturated oil here in America. Everything you buy has, whatever on it, it tells you whatever. If you just recommend 2 good oils, because I know olive oil is one, but my mom likes coconut oil. I don't know if coconut oil is good or it's not good. And also sometimes use palm kernel oil. And so I was thinking if you could list a couple of oils that are really good that you can use for everyday cooking. Because the truth is, I mean, doctor, the truth is most of our, my mom included, they will not go to the doctor, right? They wouldn't go and see a dietitian to tell them do A, B, C, D, because of the obvious reasons. But if we're able to tell them, oh, if you can use this amount of oil, avoid this. It's very easy for them to start using that. They're saying that, go and see this dietitian. First thing is thinking about, I don't have money. Second is that he's going to ask me not to do ABCD, so I'm not even going to do it. But if we're able to find a moderate way or something to let them know that this is good, it will be very, very helpful.
Yeah, thank you very much. So like I'm saying, so generally the olive oil is good, generally. And even that, you need a small amount. And a lot of the food already have got oil in it. The other types of oil, they are conflicting data. The coconut oil, palm oil, and all that is conflicting. So that's what I'm saying, that it's quite challenging for me to mention them. But general guidelines, if you can avoid salt, if you can avoid oil, that is good. And I'll still throw it back to you with the challenges I know, but the various specifics, the dietitians will be able to help. The question is the olive oil, how many can also afford the olive oil? That's another challenge. But the dietitians, they are trained to use the staples, the common foods around. They know the amount of each of the common oils around to use. That's what I'm saying, that from where I sit is quite challenging. So the multidisciplinary approach will be employed here.
Okay, so thank you very much. Okay, Santa David Safo has a question, then followed by Honorable Santa Sam. And then there's also a question that I'll read to you after that. So Santa David, please.
Thank you so much. Thank you very much, Doc. My question is, especially I can talk when I see my brothers, right? I see them, all of them, to be pregnant. And that has become like, I don't know whether it's what we eat, and then when you try to have conversation with them, right? Majority of them will say that, oh, since I'm married and I can bounce on my wife, that's my workout right there. So does that supplement it, or you know, we still need to do more. That's my question. Thank you.
That's an interesting one. Yeah, the exercise of bouncing on your wife is not enough.
Oh my goodness.
Remember, you need to do at least 30 minutes a day. 150
But
minutes.
doctor, if you're able to do the 30 minutes on hair, is it not enough?
But will she be ready?
Aha, we should be ready.
You must
30
be a
minutes,
Superman,
30
a Superman to have 30 minutes.
today. You must be a Superman.
Yes, Superman. Sister Savo, you watch too much movie.
Okay, more questions are coming. So, I mean, doctor, is it possible to limit the answers to maybe a minute or a minute and a half, maybe at least 2, so we can, yeah, because I know you're tired. You definitely need to have some rest. It's always morning there, so we appreciate you. Okay, the next question, Santa Senior Sam.
Yes,
please
so
go ahead.
Quickly, the first one is, are you going to give us forward the recording to all of us?
I think Prof said he's going to share it.
Yes. I'll share.
Yeah.
I'll upload it and share it to everyone to review. Yes, please.
Okay.
Excellent.
And then
Thank
my
you.
second question is, when you were talking about cholesterol, I mean, you mentioned the good cholesterol, the HDL, but you didn't say anything about the LDL. Isn't the ratio of LDL to HDL important to know about?
Yes, it's important, but specifically to the criteria, it's not part. But the main point is work with your primary care physician, and all those will be taken care of.
Okay. Oh, yeah.
Okay,
For a long
thank
time,
you.
I've heard that when the LDL, I mean, HDL happens to be the good cholesterol, the LDL is the bad cholesterol. And normally,
Yes.
what I've always been told is if the good cholesterol, the HDL, is very high, and say if there is enough HDL to cover the lousy, you may be okay, even though the HDL may not look good. It's just the ratio that counts more than just looking at one number.
It's 50-50.
It's 50. Okay. All right.
Okay, thank you, sir. Thank you, Senior. Doctor, there's this question for you from Mr. Benga. He said, I need a clarification. I used to assume any type 2 diseases are associated with children. How true is this?
It's not clear. Please come again.
He said he need clarification. He said he used to assume that any type 2 diabetes or diseases are associated with children. How true is this? Mr. Benga, is that a right question? I'm reading from your chat, so I'm not sure if maybe you want to clarify.
It's right.
Okay. So maybe you can repeat it for Dr. here.
Actually, the reason why I asked was in the course of the presentation, you mentioned type 2 diabetes. And before now, I used to assume that type 2 disease is associated with children, like type 2 obesity and the likes like that. So I just want to be sure, sir.
Okay, so type 2 diabetes is usually in the adults, even though it can occur in children.
Okay.
Okay, that's wonderful. Okay. Thank you, doctor. Any more questions, sir? Oh, Mr. Jude, Santa Jude, I think I saw your hand up briefly and then you lowered it. You still have a question for doctor?
No, I'm okay. Thank you.
Okay. All right. Any more questions? Doc, I have one more for you. So what are your thoughts on, health implications for late night eating, right? Especially in this country, I know that people have demanding schedules. We work 24/7. You can work from 12 a.m. midnight to 8 a.m., right? And then when it's 2 a.m. now, somebody's not going to take their lunch or dinner, right? So what do you think is the implication for late eating? I know which can be necessary for people with demanding schedules. What do you say about that?
Yes. Yeah, it's a challenging one looking at our work schedules, like you mentioned. It's bad. It's bad. Usually we advise that once you finish eating, at least you should give yourself about 3 to 4 hours to completely retire to bed. It contributes to the increased weights and the increased waist circumference that we're talking about. So it's bad.
Okay, so what would you recommend? Let's assume, take me for example, let's assume that I work from 11 p.m. midnight till 7 in the morning, right? I'm at work. I know at that time I'm working, but the work is not like hectic or tedious. But when it's 3 a.m., I had to take my lunch break. So I don't know if you call lunch or dinner or whatever break. And then I go and, grab maybe like a kinky or banku fufu, whatever. and then,
Yes.
and then, do justice to it. And then after that, I go back. I go back to work. At this point, I'm sitting at the desk or, table working. If you're a factory worker, you go up and down, so that's different, but I'll be sitting at a table working. Would you recommend that's not good enough? If it's not, then what kind of food do you want me to eat at that time? Just snacks?
Yes, so it's about the amount of calories and the glycemic index of the food.
Okay.
So you can have a large amount of food which has a lower calories and glycemic index than a smaller amount of food.
Okay.
And you need high fiber food that is easily digestible. So those ones are better than taking a heavy KK and do a sedentary work.
Okay.
So basically, we should stay away from refined carbohydrates then, is what you're saying.
Exactly. Yeah.
Okay. Thank
And
you.
refined carbohydrates meaning? Was that rice?
Yeah.
Bread? What
Yes.
else?
Okay.
Okay.
Okay. Thank you, sir. Dr. Kpodo, are you on here?
Yes, I'm on.
Okay. Would you like to ask any questions or you wanna also, chip in here?
Yes, I think that I want to ask what are how do you call it? For the people with high blood pressure, what should they limit or avoid in terms of maybe something like coffee consumption, given the mixed research on coffee effect? Yeah, Doc. Did you get my question?
Yes.
Okay.
Yes. So in terms of coffee, like you rightly said, there are conflicting data about coffee and hypertension.
Yeah.
But generally, in moderation, avoid salt and the saturated oils that we talked about, and then increase your exercises and take your medications. You should be fine.
All right, Doctor, I have a question. So my question will be, you talked about sleep deprivation and we need to have enough sleep. Now I'm looking at somebody like Professor Jude. The man is a professor. He have to do a lot of research, and yet he's very slim. So, Dr. Jude, you want to tell us what your secret is? Because we have to, professors have to sit and research and learn and mark papers and
and all that, and yet you're still slim. So what's the secret?
The secret, I think, is what Doctor. I know we are all very busy people, and then when you are busy, you tend to rack up a lot of bad habits. What Dr. Dzunu said. I think genetics has a lot to play with this. You know, I was lucky to be born in a family where everybody is very, very skinny. So what most Americans will say, you have high metabolism. So anytime I put weight, it just goes away. Secondly, amongst what we've done is ergonomics in the office. So I have a basketball court right outside my office. So if I have even a few minutes, I go there, run around, shoot the ball for a little bit. And then I also try to do brisk walking, which is about 100 steps every minute, if I can. And then every weekend, I mean, when I have a little time, I do a little weightlifting, and I also try to run as much as I can. And then I also watch how much I eat. So I cut out trans fat, saturated fat. I mostly use canola oil, olive oil, and I eat a lot of fish and seafood and some vegetables. So that helps.
Wow, good to know. Thank you
That is
so much.
awesome. That is awesome. Thank you. Thank you. Thank you,
I think
Doctor.
I think I have a question.
Yes, Santa Rez, go ahead.
Okay. This is a good topic. Okay, my question is, if I want to maintain my weight or keep the deficit down, doesn't matter when I eat. Let's say I have to consume certain amount of calories for a day. Let's say 3,000 calories for a day. And I'm able to consume that 3,000 calories. Doesn't matter if I eat it across the day, like morning, the way I have to portion it, or at one time, maybe the afternoon, I am able to consume all 3,000, or I have to spread it out from the morning to the evening.
Okay. Both can be worked out because people do intermittent fasting, which is also good. But spreading it out, in my perspective, I think is better. The temptation is that if you finish it all at a go, as time goes on, you get hungry and you tend to overindulge.
Okay.
That's the bait.
Okay. So guys, we have 2 more minutes, and then we would let Prof. J.A. just sum up this awesome meeting. We should do this more. I think we should do this like left me alone. We should do this every week, but I know it's not possible, but there will be more of this coming because this is really incredible. There's more. I'm sure we'll have more questions. So if we didn't mind, Doc, you can share your email address or your WhatsApp, and then people, whoever have questions can, shoot you some questions after this meeting. So, this conversation, this discussion can go on. All right.
Yeah,
so
fine.
one more question from, Mr. Benga again. Okay, Mr. Benga, go ahead and ask the question.
Thank you, sir, for the privilege. I want to ask about the fasting blood plasma. Which one is of the risk factor there? Is it the hypoglycemia or the hyperglycemia, sir?
Hyper.
Okay.
Dr. Kpodo, my co-host, I'm gonna leave this 2 more minutes for you to, if you want to ask questions, if you want to say anything, and then after that, Prof would, sum it up, and then we'll bring the meeting to a close. But this has been amazing. Oh, and before then, one more thing. Santaleo, are you on here? Presdo, House, are you here? House Bro, can you hear me?
Yes, I am. I was trying to unmute myself. Yes, I am.
Oh, okay. Do you have any question for Doctor?
No, I think you guys basically asked all the questions, so my question has already been answered. Very insightful.
Okay, thank you.
Thank you
all right,
much.
Dr. Kpodo.
Yeah, so I just want to emphasize that Caleb is around and available, like we mentioned earlier on, that he is a family physician, and he is one of us. And so he has mentioned that he is readily available anytime we call on him to be of help. And like we also saw it on his slide, he is a family physician and a specialist. He was at the St. Luke Catholic Hospital, but is currently the senior resident in geriatrics at the Kolebu Polyclinic. And he's also a Santa Millennium person. We are the only Millennium people. And so we are very special. And he's also a Hamlinite. Hamlin people, you know them already, Popro. They are very gentle. So the spirit of Hamlin is really on Caleb. Yeah, so he will be available. I will share his email and contact with us. And anytime that we will need his help, he will be available for us. Yeah. Yes.
All right. Thank you so much. Thank you very much. Now, Prof, would you do the honors and close us or bring this meeting to a close?
Absolutely. Dr. Caleb, once again, on behalf of the Adisadel Old Boys Association in North America, together with my fantastic host, Reverend Dr. Kendrick Kpodo and Senior Frank, and again on behalf of the North American President, Dr. Leo Ryder, I want to take this opportunity to thank you for availing yourself and taking us through this process of learning. I most importantly, I want to thank you for sacrificing your night because I'm looking at the time now, and in Ghana, probably it'll be about almost close to 2 a.m. and you are still with us, and we are very grateful. And all Santa Clausians from across the United States, Ghana, and where have you. And I see my friend Benga all the way in Nigeria joining us as well. So I wanted to thank all of you for participating. We strive to bring resources so that we don't only just have fun, but we learn as well. And we are very grateful for Professor Jude for introducing Dr. Caleb to us. And I believe that this has been amazing learning. We will get the recording to every one of you after the fact. But once again, we are very grateful and we appreciate your time with us. Thank you. And Dr. Leo Ryder, if there is anything you want to chip in, I will gladly take that. Otherwise, I'll bring the meeting to a close.
I think there are some Santa Mugas also on the platform. Nexi and yeah.
Santa Muga?
Awesome. Santa Muga, you are blessed for joining us. In future, please invite us to come to your platforms as well.
That's good. Is that Esther?
Yes.
Yeah.
Oh, okay. That's great.
Nexi. Yeah.
Nexi.
Yeah,
okay, Nexi and Esther.
Nexi and Esther.
Okay.
Yeah, I see Mercy Thompson
thank you
there
guys
as
for
well.
making time.
So, yeah. All right, Dr. Leo Ryder, you want something to say? Otherwise, we will bring the curtain down.
So you said it all. So I just want to say thanks once again, Dr. Dzunu, for sacrificing your time to do this for us. God richly bless you. So.
Thank you so much, Dr. Leo. And we are looking at hosting another forum, I think end of November, thereabout. We'll communicate that to you as well. Once again, Dr. Caleb, thank you so much. We appreciate you.
Thank you.
Every one of you have a blessed evening. And good morning to those in Africa as well. And God bless all of you. Take care. All right, bye-bye.
All right. And y'all have a
Thank
great
you.
weekend, all right? Thanks so much.
All
Thank
right.
you. Thank you.
This is
That
awesome presentation and meeting.
some of you can on your camera.
Hey,
Let's see
David.
your face.
Oh my God.
Yeah, how
I
are
see,
you?
I see David. I haven't seen him for a long time.
Yes, please on your camera. Let's see your face.
Now let's see your face.
I know.
Oh
You
my
see all the gray hair?
God.
Yes.
I know. David, where have you been? I haven't seen you for a long time.
Wow.
And you, Mr. Poku. Oh my goodness.
Yes. Hey, Prof. Jude, God bless you.
It's been almost like
Even Prof. Jude have a gray, so I'm not concerned. I mean, he finished in 2000 and has a gray hair. I'm okay. I mean,
Maybe gray is genetic. Let me speak
all
for him.
right.
All right, you guys have a good night and good morning.
All right, guys.
All
Yeah, y'all have a good
Let's see you
weekend.
guys. So bye bye.
All right. Bye.